Welcome back to the deep dive. Today, the vibe in the studio is a little different. Usually, we are relaxed, we are curious, we are just exploring ideas. But today, my palms are sweating just a little bit.
I can feel it.
Because today, we are simulating the walk down that long, quiet corridor to the exam hall. We are stepping into the shoes of a final-year MD anesthesiology student facing the Gujarat University examiners.
The pressure cooker, I remember that walk well. And honestly, for anyone listening who isn't actually taking that specific exam, don't tune out.
No, definitely not.
Because what we are doing today is essentially a masterclass in advanced airway management. We are stripping away the fluff and focusing purely on examiner-centric knowledge regarding tracheostomy.
Exactly. I've got my stack of books here. I'm looking at Miller's Anesthesia, Osteointensive Care Manual, Morgan and Mikhail, but I don't have time to read 200 pages right now.
Nobody does.
I need the extraction. I need the examiner-centric gold. Our mission is tracheostomy. Indications, techniques, complications, and management.
And that is a topic that smells like fear in an exam. It's the ultimate crossover topic. It's surgical, it's airway, it's ICU, and it's emergency management.
All in one.
All in one. If you're sitting in Aviva and they hand you a tracheostomy tube, you can either look like a consultant or you can fail the station in 30 seconds.
That is terrifying.
Yeah.
So let's structure this exactly how the exam demands. We need to cover the long question, that massive 20-mark essay structure.
Yep.
We need the short note on PDT.
Yep.
And we need to survive the table Viva traps. Let's start with Part A, Introduction and Exam Framing. If I open that exam paper and see tracheostomy as the long question, how do I start without rambling?
You start with the definition. Crisp and precise. Do not just say it's a hole in the neck.
Right, that's too basic, undergraduate level.
Exactly. You define it strictly as a surgical procedure creating an opening, an artificial opening, in the anterior aspect of the neck to access the lower airway through the trachea.
Okay, specific.
And here is where you grab your first nuance point from Miller's anesthesia. The difference between tracheotomy and tracheostomy.
Oh, I saw this in the notes. It's the suffix, right? The tomy versus stomy.
Exactly. It's etymology, and examiners love it because it shows you respect the language of medicine. Tomiati comes from the Greek tome, meaning to cut.
Okay, so the cut itself.
The act of slicing the skin and trachea, that's the tracheotomy.
So the act is the tomy.
Correct. But stomy, S-T-O-M-A, means mouth or opening. So the tracheostomy is the actual semi-permanent opening where the tube lives, the stoma.
The maintained opening.
Yes, the skin is sewn to the trachea or held open by the tube. Clinicians use the words interchangeably, in day-to-day practice.
Sure, everyone does.
But if you write that distinction down in your exam, tracheotomy is the cut, tracheostomy is the opening. It shows you've read the big books. It's an easy mark.
Nice. Easy points right off the bat.
Yeah.
Now, context. Why do we do this? Why not just leave the endotracheal tube in forever?
It's about the long game. Historically, and still today, it's the definitive substitute for endotracheal intubation. We'll call it ETT.
Yeah, ETT.
Either to bypass an upper airway obstruction or, much more commonly for long-term ventilation.
Okay, so the clinical importance, what are the bullet points for my intro?
Okay, 4 key things, and you should list them just like this. 1, it reduces dead space. We'll get into why later.
Okay.
2, it reduces the work of breathing. Hugely important for weaning.
Right.
3, it improves patient comfort. They can potentially eat. They can vocalize a bit. It's much more humane than an ETT.
I'm 4.
4, it facilitates pulmonary toilet.
Pulmonary toilet. I always love that term. It sounds so undignified, but it's crucial.
It is. It just means you can stick a suction catheter down there and clean out the lungs easily. If a patient has a weak cough, that ability to suction is the difference between pneumonia and recovery.
Makes sense.
And the other big one, which is sort of linked to comfort, is sedation holidays.
Oh.
With an ETT, the patient usually needs some sedation to tolerate that big plastic tube in their throat. It's really uncomfortable.
Yeah, you see them gagging on it all the time.
Exactly. With a track, it's much more comfortable, so you can often wake them up completely. You can stop the propofol and start weaning them from the ventilator much sooner. It accelerates the whole process.
Okay, so that's our intro and framing. I feel good about that. Now let's move to Part B, Anatomy and Physiology. The outline marks this as absolutely essential and exam core.
You cannot bluff the anatomy. You just can't. If you are discussing the surgical technique in an exam, you need to visualize the layers.
Okay, so let's do that. Picture the neck. Where do I start?
Start with the surface landmarks. What can you feel? You have the laryngeal prominence, the Adam's apple.
Got it.
Below that, you feel a gap and then a hard ring. That is the cricoid cartilage.
Level C6.
Correct, C6 level. And the cricoid is unique because it is the only complete cartilaginous ring in the entire airway.
The only one that goes all the way around.
It's a full circle, like a signet ring. Everything below it, the tracheal rings, are C-shaped.
Right. The tracheal rings are open at the back.
Exactly. They are D-shaped with the flat part at the back, and that flat part, the membranous posterior wall, lies right against the esophagus.
Which is a huge deal.
It's a massive danger zone. If you push too hard with a needle or a dilator during the procedure, you can punch right through the back of the trachea and into the esophagus.
Creating a TT tracheoesophageal fistula.
Exactly. A disaster. Now, let's talk numbers. Exams love numbers. The trachea extends from the cricoid to the carina. In an adult, that length is about 10 to 13 centimeters.
Okay.
The magic number, to quote, is that the distance from the cricoid to the carina is approximately 11 centimeters.
11 centimeters. That doesn't seem like a lot of room for error.
It isn't. And that brings us to the danger zone regarding blood vessels. This is what keeps surgeons and anesthetists awake at night.
Okay.
Let's do a mental dissection. You are cutting down the midline. What layers are you passing through?
Okay. So skin, subcutaneous fat.
Right. Then the platysma muscle. Then you get to the investing layer of deep cervical fascia. Then you find the strap muscles, the sternohyoid and sternothyroid, and you separate them in the midline.
You retract them laterally.
Exactly. And then you hit the pretracheal fascia. And sitting right there, usually mocking you, is the thyroid isthmus.
And this usually sits over the second, third, and fourth rings.
Usually. But anatomy is rude. It varies. Sometimes it's high, sometimes it's low. But you have to deal with it. You can retract it up, you can retract it down. But Morgan and Mikhail is very specific here. For the exam, you mentioned division and ligation.
Cut or tie.
Yes, because if you just retract it, it can slip back over the stoma later and cause obstruction or bleeding. So division and ligation is the definitive answer.
Got it.
But looking deeper, below the isthmus, we enter the real danger zone, the innominate artery, the brachiocephalic.
There's that exactly.
In relation to the trachea. It crosses the trachea low down in the neck, usually behind the sternum, but, and here's the catching children, or in people with very narrow necks, it can ride high.
So it's more vulnerable.
Much more. If you place a tracheostomy too low, say below the fourth ring, or if the tip of your curved tube angles forward and erodes over time,
It can eat right into that artery.
it can erode through the tracheal wall and into that artery,
A tracheoinnominate fistula.
which is essentially an arterial blowout into the airway. We will talk about managing that in the emergency section, but anatomically, you must know it's there.
Okay.
And don't forget the nerves, what's running on either side.
The recurrent laryngeal nerves.
In the tracheoesophageal groove. Stray too far laterally with your dissection and you paralyze a vocal cord. Unilateral is bad, bilateral is a catastrophe.
Right. So midline, midline, midline.
That's the mantra. Stay in the middle.
Let's pivot to physiology. We mentioned dead space earlier. Can you unpack that for me in exam terms?
Sure. Let's get a little nerdy with the physics. Anatomical dead space is the volume of air in your conducting airways, nose, throat, trachea that doesn't reach the alveoli for gas exchange.
It's just fill in the pipes.
Exactly. When you breathe through your nose and mouth, that path is long. When you breathe through a tracheostomy, you are bypassing the entire upper airway. You are cutting that path in half, sometimes more.
So the ratio of dead space to tidal volume, the VDVT ratio goes down?
Exactly. For a standard tidal volume, more of that air is actually participating in gas exchange. This means the patient doesn't have to breathe as deeply or as frequently to maintain their blood gases.
Which means less energy expenditure.
It all contributes to lowering the overall work of breathing, but the bigger factor is resistance.
Poiseuille's law.
That's the one. Resistance is inversely proportional to the radius to the power of 4 and directly proportional to length.
So a long, thin tube has high resistance.
Right. An endotracheal tube is long, maybe 30 centimeters. A tracheostomy tube is short, maybe 8 centimeters.
So simply by shortening the tube, you drop resistance significantly.
Drastically, which again decreases the work of breathing, or WOB. This is huge for a patient who is weak and trying to wean off the ventilator.
Okay, but is there a catch?
However, and this is a distinction level point for the exam, remember the radius factor, a very small tracheostomy tube, say a size 6.0, can actually have higher resistance than a normal airway because the radius is so small.
Oh, interesting.
So the benefit really kicks in with appropriate sizing. Size 8.0 is usually the sweet spot for adult males, 7.0 or 7.5 for females.
Is there a downside to bypassing the nose, physiologically speaking?
Definitely. The nose isn't just a tube, it's an air conditioner. It warms and humidifies the air we breathe. It's the mucociliary escalator.
Right.
When you bypass it, you lose that humidification. The secretions in the lungs get dry, thick, and sticky. We call that inspissation. It's like concrete. That's a huge problem.
And what about the laryngeal braking mechanism? I've seen that term.
This is a subtle but important physiological point. Normally, when you exhale, your vocal cords narrow slightly. This creates a tiny back pressure, a physiological peep.
Positive and expiratory pressure.
Right. A natural peep that helps to keep your alveoli open at the end of expiration.
Under the tract, you lose that.
You lose that completely. The air just dumps out of the hole in the neck. So unless you add some external PEEP or CPAP from the ventilator, these patients are prone to basal atelectasis. Their lung bases collapse because they lost that natural back pressure.
Fascinating. Okay, let's move to part C, indications and types. This is labeled exam gold. If I'm writing the long answer, how do I organize the indications so I sound professional?
Don't just list them randomly. Categorize them. It shows organized thinking.
Okay, what are the categories?
Category 1, upper airway obstruction. This is the classic life-saving indication.
So things like infections.
Yes.
Yeah.
Think infections like Ludwig's angina, where the floor of the mouth swells up, or epiglottitis. Trauma, like severe maxillofacial fractures where you can't intubate orally.
Tumors.
Tumors of the larynx or thyroid that are compressing the airway. Or bilateral vocal cord paralysis where the cords are stuck closed. Basically, anything blocking the door from above.
Got it. Category 2.
Prolonged mechanical ventilation. This is the most common reason in the ICU today.
Right.
The TrackMan trial is the famous study here. Generally, if a patient is going to be on a ventilator for more than 7 to 14 days, we start thinking about a track.
And why is that?
It prevents laryngeal stenosis from the ETT pressing on the vocal cords for weeks, and like we said, it makes weaning much, much easier.
Is there a hard rule on the days, 7 days, 10 days? I feel like this is always debated.
It is. The TrackMan trial showed that doing a tracheostomy very early, like within 4 days, didn't necessarily improve 30-day mortality compared to doing it later after 10 days. So the consensus is usually to make a decision around day 7 to 10 based on clinical judgment.
So it's not a race.
It's not a race. If you know the patient isn't waking up anytime soon, say a severe head injury, you might do it earlier. If you think they might just turn a corner tomorrow, you wait.
Okay. Category 3.
Pulmonary toilet. This is for patients who cannot clear their own secretions.
So neurological causes mainly?
Yes. Bulbar palsy, a big stroke, Guillain-Barré syndrome, they are literally drowning in their own mucus, and the track gives us a direct route to suction them out effectively.
And what about airway protection? Is that its own category?
I'd put it as number 4, prevention of aspiration in patients with no gag reflex, maybe after a head injury. But, and this is a crucial exam nuance,
Okay.
a cuffed tracheostomy tube does not guarantee 100% protection against aspiration.
Right. I remember reading that. Why is that?
Liquid can still trickle down the microscopic channels in the cuff folds. Microaspiration happens. It's much better than a completely unprotected airway, but it's not a perfect seal. You have to mention that to show you understand the limitations.
Are there any absolute contraindications?
Very few absolute ones because it's often a life-saving procedure, but there are strong relative contraindications that you must mention.
Okay.
1, if the patient requires very high oxygen and FiO2 over 80%, or high PEEP over 10 centimeters of water.
Why is that a contraindication? It seems like they need a secure airway more than anyone.
Because during the procedure, specifically the percutaneous one, you have to disconnect the circuit and stop ventilation to swap the tubes or dilate the tract.
So they have no reserve.
They have zero reserve. They will desaturate instantly and potentially have a cardiac arrest on the table. You have to stabilize them first.
Okay, that makes sense. What else?
2, uncorrected coagulopathy. Especially for a percutaneous tracheostomy, a PDT, you are poking a hole blindly. If they have an INR of 3 or platelets of 20,000, you're going to cause a massive hematoma that compresses the airway.
So you have to correct the numbers before you start.
You have to. Or opt for an open surgical procedure where you can actually see and control the bleeding vessels.
Let's distinguish the types of tracheostomy. The outline mentions high versus low. What does that mean?
This is an anatomy question. It's about where you make the hole in the trachea.
Okay.
A high tracheostomy enters above the thyroid isthmus at the first or second ring. This is bad practice.
Why?
It's too close to the cricoid cartilage and can cause subglottic stenosis, a scarring and narrowing of the airway that is very, very hard to fix.
Okay, so avoid high. What about low?
A low tracheostomy is below the isthmus. This is also dangerous. Why?
The innominate artery.
The innominate artery we talked about. High risk of erosion and catastrophic bleeding.
So we want to be in the middle.
The mid-tracheostomy is the sweet spot, behind the isthmus, entering at the second, third, or fourth rings. That's the ideal location.
And the other big distinction is surgical versus percutaneous, the PDT.
Correct. Surgical is done in the OR, open incision, direct visualization. It's better for patients with difficult anatomy, short fat necks, or big goiters.
And PDT.
PDT is done at the bedside in the ICU using the Seldinger technique guide wires and dilators. It's faster, it's cheaper, but it really requires the patient to have normal neck anatomy. We'll get into the details of those now.
Perfect. Which brings us to Part D technique. Let's start with the classic surgical tracheostomy. This is exam core. Walk me through the steps, focusing specifically on what I, as the anesthetist, need to be doing and thinking about.
Okay. Step 1 is positioning. You want the trachea to be as superficial and accessible as possible. So patient is supine, and you put a sandbag or a shoulder roll under their shoulders to extend the neck.
To bring the trachea forward.
Exactly. And a little head-up tilt, maybe 15 to 20 degrees, to drain the veins in the neck and reduce bleeding.
The surgeon makes the incision.
Usually a transverse or collar incision for cosmetic reasons, about midway between the cricoid and the suprasternal notch.
Okay.
They dissect down in the midline, separate the strap muscles, ligate the thyroid isthmus. Then they identify the trachea itself. They might confirm it by aspirating air with a needle and syringe.
And then the cut into the trachea.
Right. They can make a simple window, a cruciate cut. But a key term to drop in your exam answer is the Bjork flap.
Bjork flap. So I see this in the textbooks. What is it exactly, and why is it important?
It's where the surgeon cuts an inferiorly based flap of the tracheal wall.
So a U-shaped cut opening downwards.
Exactly. And they take that little flap and suture it to the skin of the neck. It creates a little ramp.
A ramp.
Yes. If the tube falls out accidentally in the first few days before the tract is mature, that flap keeps the hole open and basically guides the tube back into the trachea. It's a huge safety feature, especially for decannulation emergencies.
That's brilliant. Okay, now the critical moment, the airway exchange. I want to slow down here because this feels like the part where careers can end. I'm at the head of the bed. The surgeon is ready to put the tract tube in. But my oral ETT is in the way. What is the dance?
This is all about closed-loop communication. It has to be perfect. The surgeon will say something like, "Trachea is open. I'm ready to insert."
Okay, what do I do?
You, the anesthetist, check your monitor. Is the patient fully paralyzed? Are they 100% oxygenated? You have to be ready for a period of apnea. You say, ready.
Okay.
The surgeon says, withdraw the ETT. Now, what's the very first thing you do before you pull?
Deflate the cuff.
Even before that, suction the mouth and pharynx.
Ah, of course. So gunk doesn't fall down into the lungs.
Exactly. So you suction thoroughly, then you deflate the cuff of your oral ETT completely, and you pull back slowly.
How far do I pull back?
You are watching the surgeon. The surgeon is looking into the hole they just made in the neck. They want to see the tip of your EPT slide up past their incision. As soon as they see the cuff clear the window, they'll yell, "Stop!"
And I hold it there. I freeze.
You freeze. The tip of your tube is now sitting just above the vocal cords or high in the subglottic space. It is not out of the patient.
Why not just take it out completely, get it out of the way?
Because what if the surgeon can't get the tract tube in? What if the hole collapses? What if there's a massive bleed right at that moment?
Then you've lost the airway.
You have completely lost the airway. By leaving the tube just above the cords, if disaster strikes, you just push it back down a few centimeters, inflate the cuff, and you are ventilating again. It is your lifeboat.
Okay, that's a critical safety step.
Absolutely critical. Only when the surgeon says tract's in, cuff is up, and you've connected your circuit to the new tract tube and see a beautiful CO2 waveform on your monitor. Only then do you remove the oral ETT completely.
Got it. Confirm placement first.
Always. End title CO2 is your confirmation.
Now, let's talk percutaneous dilatational tracheostomy, PDT. This is listed as very high yield for short notes.
Yes, because PDT is the standard in most ICUs now for elective cases. It uses the Seldinger technique, just like putting in a central line.
Okay, walk me through it.
Step 1, bronchoscopic guidance. This is the gold standard. You pass a flexible bronchoscope down the existing ATT.
So you're watching from the inside.
Exactly. You're watching the anterior wall of the trachea on a screen. Step 2. The operator punctures the trachea between the second and third rings with a needle. You watch the needle indent the wall and then pop into the lumen right on the screen.
That's much safer than doing it blind.
Infinitely safer. Step 3. They pass a guide wire through the needle into the trachea. Step 4. They remove the needle and dilate the tract over the wire. The Siaglia blue rhino is the most common single-tapered dilator. It looks like a curved rhino horn.
And you just push that in to stretch the hole?
You gently advance it to stretch the hole to the right size. Step 5. You slide the tracheostomy tube over the dilator and into the trachea. Then you pull the dilator and guide wire out, inflate the cuff, and confirm with your CO2 trace.
Why is the bronchoscope so important? What's the main thing it prevents?
Posterior wall puncture. Remember we said the esophagus is right behind the thin membranous part of the trachea? If you push that needle too hard without seeing where it's going, you can easily stab the esophagus. The scope lets you see the needle enter the lumen of the trachea safely and stops you from going too far.
Okay. And the main advantages of PDT over surgical?
It's a bedside procedure. You don't have to transport a critically ill, unstable patient to the operating room. That's a huge plus.
Right. Avoids the transport risk.
Also, a smaller skin incision, which means less infection and better cosmetic result. It's generally faster and more cost-effective.
But the disadvantage is that it's still a semi-blind procedure, right?
Correct. Even with the scope, you don't have the same direct vision of the surrounding vessels, so it's not for patients with difficult anatomy, previous neck surgery, or, as we said, coagulopathy.
Moving on to Part E, anesthetic management. Pre-op prep.
We've covered some of this. You're going to check coagulation, PTINR, platelets. You need to optimize FiO2 to 1.0 to pre-oxygenate them as much as possible.
Build that reserve.
Build that reserve for the apnea period. And you must have the difficult airway cart in the room and ready.
Plan B.
Plan B, C, and D. You need smaller ETTs, a laryngeal mass airway, cricothyroidotomy kit. You have to be prepared for total airway loss.
What about anesthesia type? GA versus local. How do you decide?
For 99% of cases, especially elective ones, general anesthesia is standard. You have a secure airway with the ETT, you have controlled ventilation, the patient is still and comfortable.
Okay. When would you ever use local?
Consider the patient with a massive friable upper airway tumor, or Ludwig's angina where the neck is rock hard and swollen shut.
The ones you're terrified to induce.
Exactly. If you put them to sleep and paralyze them, the airway muscles relax, the tumor might flop over and block everything completely. You might find yourself in a cannot intubate, cannot ventilate situation.
The ultimate nightmare.
It is. In that specific high-risk scenario, you may opt for an awake tracheostomy under local anesthesia.
That sounds incredibly stressful for everyone involved.
It is the most stressful procedure you will ever be a part of. You use local infiltration lidocaine with adrenaline along the incision line. You might do a superficial cervical plexus block, but you keep the patient breathing spontaneously the entire time.
You're talking to them.
You're talking to them, reassuring them. You give them just enough sedation to tolerate it, but not so much that they stop breathing. You do not paralyze them until the surgeon has confirmed the trachea is open and the tube is in and secure.
Maintain spontaneous ventilation at all costs.
At all costs.
And there's a note here about fire safety in the intraoperative considerations. Seems like a classic exam question.
It is a classic. What is the fire risk during a tracheostomy?
Okay, what is it?
When the surgeon cuts into the trachea, there is oxygen-rich gas leaking out of the hole from your ventilator circuit. If they then use diathermy or cautery to cut the trachea or control bleeding right at the edge of the opening.
Spark plus oxygen.
Equals a fire. You get a blowtorch effect right in the patient's airway. It is devastating.
So what's the rule?
The rule is, do not use diathermy to enter the trachea. The surgeon must use a cold knife, a scalpel or scissors only for that step. And as the anesthetist, you should try to reduce the FiO2 to as low as is safely possible right before they make the tracheal incision.
Okay, no cautery on the airway. Got it.
Yeah.
Part F complications. Absolutely essential. Let's break this down into early and late.
Okay, early complications. These happen immediately in the OR or within the first 24 to 48 hours.
Number 1.
Hemorrhage. This is the most common one. Usually it's venous bleeding from the anterior jugular veins or the thyroid isthmus, usually controllable.
Okay.
Number 2, pneumothorax. especially in children or in COPD patients with large bullae, where the apex of the lung pleura can rise up high into the neck. If the dissection goes too deep and too lateral, you can pop the pleura.
How would you know that's happened?
Suddenly, high peak airway pressures, drop in saturation, and decreased breath sounds on one side. You'd need a chest x-ray and a chest drain. Subcutaneous emphysema. This is dramatic to see. The patient puffs up like the Michelin Man. Their face, neck, chest, all full of crackly air.
Why does that happen?
Usually it's because the skin has been sutured too tightly around the tube. Air leaks out of the tracheal stoma, but it can't get out of the skin incision, so it tracks into the subcutaneous tissue.
Is it dangerous?
It's alarming, but usually self-limiting if you loosen or remove a couple of skin sutures to let the air escape. The bigger worry is that it might be a sign of a false passage.
A false passage.
Yes. The tube isn't in the trachea at all. It's sitting in the pretracheal tissue. That's our fourth early complication. Tube misplacement. A true disaster.
Okay, and leak complications. These are the ones that show up weeks or months later.
Number one is tracheal stenosis, a narrowing of the trachea. This is usually due to the cuff.
Too much pressure.
Exactly. If the cuff pressure is too high, consistently greater than 25 or 30 centimeters of water, it exceeds the capillary perfusion pressure of the tracheal mucosa.
It cuts off the blood supply.
It cuts off the blood supply, the mucosa becomes ischemic, it dies, it scars down, and the trachea narrows at that spot. This is why regular cuff pressure monitoring is so important.
Right. What's next?
Tracheoesophageal fistula, or TF. We mentioned the risk. It's due to erosion of the posterior wall, either from the cuff pressure or the tip of the tube rubbing against it.
To what else?
Granulation tissue. Little fleshy cauliflower-like growths can form at the stoma site or at the tip of the tube. They can bleed easily or even grow large enough to obstruct the tube.
Part G, tracheostomy emergencies. This is Viva Gold, the examiner asks. You are the anesthetist on call for the hospital. You are called to the ward. A patient's tracheostomy tube has fallen out. It was put in yesterday. What do?
This is the accidental decannulation scenario. It is a tract. The entire answer depends on one question.
What's that?
Is it a fresh tract or a mature tract?
And what's the cutoff? How do you define that?
Usually 7 days. It takes about a week for the tract to epithelialize, to heal into a stable tunnel from the skin to the trachea.
Okay, so in this scenario, it was put in yesterday. It's a fresh tract.
It's a fresh tract. The tissue planes, skin, muscle, fascia, trachea, are all still soft and mobile. The second the tube comes out, they will slide over each other and the hole will disappear.
So what's the rule?
The golden rule: do not blindly poke a tube back into a fresh stoma.
Why not? I mean, if the hole is right there, you can see it.
It looks like it's there, but if you try to force a tube in, you will almost certainly miss the small collapsed tracheal opening and slide into the pretracheal space instead.
You create a false passage.
You create a false passage.
Right.
Then you attach a bag and ventilate. You pump air into the soft tissues of the neck, which then compresses the real airway from the outside. The patient will desaturate and die of hypoxia, and you will have caused it.
Okay, so for a fresh tract, what is the algorithm? What do I say in the exam?
1, call for help. Anesthetic senior, ENT surgeon, crash team.
Right.
2, apply high-flow oxygen to the patient's face and over the stoma. They might be able to get some gas in through the hole.
Okay.
3, do not poke the neck.
And 4.
4, perform oral intubation. Treat it like a standard difficult airway. Secure the airway from above. Once the patient is stable and intubated, you can then take them back to the OR and have the surgeons redo the tracheostomy in a controlled setting.
Okay, that's a very clear, safe answer. Now, what if it's a mature tract, say 3 weeks old?
Then you have a well-formed tunnel. It's much safer. You can attempt to reinsert the tube.
Oh.
You use the obturator that comes with the tube to give it a smooth, rounded tip. You gently try to reinsert it. Or, even better, you can try a smaller sized tube first. Or put a gum elastic bougie into the stoma, feel for the tracheal clicks, and then railroad the tube over it.
But what if you meet resistance?
If you meet any resistance, you stop. Oral intubation is always the ultimate safety net for a fresh or a mature tract. If you can't secure the airway from the neck, secure it from the mouth.
Another emergency, the blocked tube. What are the steps?
Very common. Usually it's a thick mucus plug. Step 1 is the easiest and often works. Remove the inner cannula. Most tubes have an inner tube you can just pull out and clean or replace. If the plug is in there, you've solved the problem instantly.
And if that doesn't work?
Step 2, pass a suction catheter down the tube. If it goes in easily, the tube is patent. If it stops, it's blocked.
Okay.
Step 3, deflate the cuff. Sometimes the cuff can herniate over the end of the tube and cause an obstruction. Deflating it might relieve it.
And if you still can't pass a suction catheter after all that.
The tube is definitively obstructed. You must remove it and replace it with a new one, just like in an accidental decannulation.
Now the bleeding emergency, the big one. We talked about the innominate artery earlier. Let's talk about the sentinel bleed.
This is absolutely vital for any exam. A small amount of bright red, pulsatile blood from the stoma, maybe just a teaspoonful, is often a warning sign.
A warning for what?
It's called a sentinel bleed. It means the tracheoinnominate fistula has formed and is leaking slightly before the main catastrophic blowout. You must not ignore it. If a nurse calls you about a small bleed, you have to go see it immediately and get the surgeons involved.
Okay. Now, the worst case scenario happens. The massive hemorrhage. Blood is hitting the ceiling. What is the immediate maneuver? This is the Utley maneuver, right?
Yes.
You have seconds to act.
What's step one?
Step 1. Hyperinflate the cuff of the tracheostomy tube. Shove 20-30 mils of air in there. Sometimes the balloon itself will expand and push against the artery wall and temporarily stop the flow.
And if that fails?
If that fails and blood is still pouring out, you have to perform digital compression.
Paint the picture for me. What am I physically doing? I need to be able to describe this.
You remove the tracheostomy tube. Yes, you take it out completely. You insert your index finger directly into the stoma. You slide it down along the interior surface of the trachea until you are behind the manubrium, the top of the breastbone.
Okay, I'm in the chest. You are in the chest. Then you hook your finger forward, pulling up.
So I am pinching the artery between my finger inside the neck and the back of the sternum outside.
Exactly. You are manually clamping the innominate artery against the posterior surface of the manubrium. The bleeding should stop, or at least slow dramatically.
Oh, wait.
And then you are the clamp. You cannot let go. You climb onto the gurney, your finger deep in the patient's chest, and you ride with them to the operating theater for an emergency sternotomy. That is the only way they survive.
That is intense. But if you say digital compression of the innominate artery against the manubrium in the exam, you've basically passed the station.
Absolutely. It shows you know the anatomy and you know the desperation of the situation and exactly what to do.
Let's take a breath and move to Part H, postoperative and ICU care. This feels a bit calmer.
Once the tube is in and secure, the care is routine but vital.
Number 1 has to be humidification.
It's non-negotiable. You bypass the nose, so you must replace its function. You use a heat-moisture exchanger, or HME, the little plastic nose, or a heated, humidified circuit from the ventilator.
And if you don't?
If you don't, the secretions turn to concrete, as we said. They form thick plugs that can block the tube or the smaller airways.
Number 2, suctioning.
Yes, it must be a sterile technique. You pre-oxygenate the patient before you suction, and you don't suction for longer than 10 to 15 seconds at a time to avoid hypoxia and trauma to the mucosa.
And cuff care.
You need to monitor the cuff pressure regularly with a manometer. The goal is to keep it between 20 and 25 centimeters of water, just enough to create a seal for ventilation, but not so much that it causes tracheal ischemia.
Weaning and decannulation. When do we finally take it out?
We often use special tubes for weaning. A fenestrated tube is a common one.
What does that mean?
It has a hole or a fenestration in the outer curvature of the tube. When you remove the inner cannula and deflate the cuff, air can go up from the lungs through the fenestrations into the vocal cords. This allows the patient to speak.
And the speaking valve. I see the Passy-Muir valve used a lot.
That's a one-way valve. It sits on the end of the tract tube. It has a diaphragm that opens to let air in when the patient inhales, but it closes when they exhale. So the exhaled air is forced to go up around the outside of the tube and through the vocal cords so they can talk in a much more natural voice.
Okay, there's a huge safety point here, isn't there?
A critical exam safety point. If you put a speaking valve on, you must deflate the cuff. You have to write that in bold in your mind.
Why is that so absolutely critical?
But think about the physics. The valve lets air in, but it blocks air from coming out through the tube. If the cuff is still inflated, the air can't get up around the tube either.
So the air is trapped.
You have created a one-way system that is just filling the lungs. The patient can breathe in, but cannot breathe out at all. You will cause breath stacking, a massive tension pneumothorax, and cardiac arrest within minutes.
So the mantra is?
Cuff down in, valve in, always.
Decannulation criteria. When is the patient ready?
The patient must be able to protect their own airway. That means they have a good swallow and a strong, effective cough. The original reason for the trach, like an upper airway obstruction, must be resolved, and their secretions must be minimal and thin.
And how do you test that?
If they pass those checks, we often downsize to a very small tube and then cap it for 24 hours. If they can breathe perfectly fine with the cap on, tolerating it without any distress, then we know they don't need the trach anymore. We pull the tube and cover the stoma with an occlusive dressing. It usually closes on its own in 5 to 7 days.
Finally, part 1. Exam integration. Let's hit the comparison tables in Viva Traps. Tracheostomy versus ETT, quickfire pros and cons.
Okay, tracheostomy pros. Lower dead space, lower work of breathing, better patient tolerance, allows eating and speech, very stable airway for long-term care.
Yep. ETT pros.
Quick and non-invasive to place in an emergency, protects against aspiration a little better initially, no surgical risks.
Okay. Tracheostomy cons.
All the surgical risks.
Oh,
Bleeding, pneumothorax, nerve injury, stoma scars, risk of late complications like tracheal stenosis.
And ET cons.
High airway resistance, very uncomfortable, so it usually requires sedation, and significant risk of laryngeal and vocal cord trauma if it's left in for too long.
Perfect. Right. Next comparison. Surgical tracheostomy versus PDT.
Okay. PDT pros. It's faster, it can be done at the bedside, smaller hole, less bleeding, and it's cost-effective.
And the downside.
It's a semi-blind procedure, higher risk of posterior wall puncture or creating a false passage. It's not good for patients with difficult anatomy.
And surgical pros.
Better for those patients with difficult anatomy. You have direct vision, so bleeding is better controlled, and you can create a Bjork flap for added security.
The downside being?
It requires transport to the OR, it's a bigger procedure, and there's a higher risk of wound infection.
Great. And let's just recap the common exam questions in Viva Traps one last time.
Trap number 1. The examiner asks, how do you do a tracheostomy?
And the trap is jumping straight to the knife.
Exactly. The answer is not, I pick up a scalpel. The answer is, first, I would assess the indications. I would ensure all contraindications are considered. I would check the coagulation and get informed consent, and then I would position the patient. Show them you are a safe, thoughtful doctor before you are a technician.
Trap number 2. The patient desaturates during the procedure.
Don't just say, give more oxygen, be systematic. My first thought is an airway problem. I would immediately check the position of the ETT. Has it been pushed too deep into the right main bronchus, or has it been withdrawn too far out?
DCOPE.
Exactly. Dislodgement, obstruction, pneumothorax, equipment failure. Check for pneumothorax. Check for circuit disconnection. Be an anesthetist.
And trap number 3. Management of massive hemorrhage.
Don't just say, call the surgeon. You are the first responder. You say, my immediate actions would be to hyperinflate the cuff, and if that fails, I would perform digital compression of the innominate artery while calling for urgent surgical help. Use the keywords.
And for the written exam diagrams, what should I be able to draw?
Practice drawing 2 things. First, a simple cross-section of the neck showing the relations. Trachea in the middle, esophagus right behind it, thyroid isthmus in front, strap muscles, and the great vessels laterally. It shows you on the anatomy.
And the second one?
A schematic of the Seldinger technique for PDT. 4 simple steps. Needle, wire, dilator, tube. Simple line drawings score very high marks because they show you understand the process.
And for the conclusion of the big 20-mark essay, how to wrap it all up.
You summarize nicely, something like, in conclusion, tracheostomy is a definitive airway procedure with significant physiological benefits for long-term ventilation, specifically the reduction in anatomical dead space and work of breathing. However, it is not without significant risks, both immediate and delayed, particularly hemorrhage, airway loss, and tracheal stenosis. The role of the anesthetist is therefore crucial in preoperative optimization, ensuring intraoperative airway security during the critical exchange and the rapid recognition and management of life-threatening complications.
Fantastic. This has been a true deep dive. I feel like I can actually visualize the layers of the neck now.
And that visualization is the key. If you can see the anatomy in your mind's eye, you can reason through any question they throw at you.
To the student listening, remember the 11 centimeters from cricoid to carina? Remember the sentinel bleed? And please, remember, cuff down, valve on. You've got this. Go ace that Viva.
Good luck.
Thanks for listening to The Deep Dive.